This is the case of a terminal approach for a cavernous sinus dermoid cyst in a 6-year-old boy that presented with headaches and ptosis. We are doing a middle fossa approach, finding the location of V3 and foramen spinosum. Now we coagulate and transect the meningoorbital band. This dural fold after transection gives us access to the supraorbital fissure, anterior cranial process, and lateral wall of the cavernous sinus, all in an extradural fashion. We keep peeling this dura gently until we start exposing the lateral wall of the cavernous sinus. We continue dissecting this dura down to the level of V2. Usually there are dural attachments that need to be transected with scissors at this level. Once we liberate those dural attachments, we can continue our peeling of the dura of the temporal lobe away from the cavernous sinus wall. We can now see the whole body of the anterior clinoid process, and now we're along the middle cranial fossa, dissecting along V2, which can be seen displaced by the tumor mass. We are now stimulating, finding the third nerve located at the roof of the cavernous sinus, just underneath the clinoid. We can see V2 displaced inferolaterally, and the whole dermoid cyst. We open the capsule, and again all is done in an extradural fashion with no fixed bend retraction. We identify the contents that are typical of a dermoid cyst. At this point the operation just consists on gradual debulking, being careful with the surrounding cranial nerves, remembering that cranial nerve 3 is located superiorly and V1, V2 are displaced inferiorly. This case was done at the Children's Hospital, Stanford Children's Hospital, along with Professor Gerald Grant. We believe in combining expertise with the pediatric neurosurgeons when we have skull-based cases to achieve the best possible outcome. We are now looking into the deepest portion of the tumor, and we use an interesting feature here of augmented reality to superimpose the location of the cavernous carotid artery. And this helps us with our resection, but especially the Doppler ultrasound is very useful to map the carotid as we get to the deepest portion of the tumor resection. There is still a membrane that is stuck to the carotid artery and to the cranial nerves, and that membrane we are not going to remove. The morbidity of doing so is just too high and is unnecessary. We just want to really peel off all the contents, make sure there is nothing left. We irrigate profusely the cavity. We even use the endoscope to take a look at the end also, and we remove any potential residual tumor. We stimulate the nerves at the end of surgery. We V3 down inferiorly and 3 superiorly. Patient had an excellent outcome with recovery of the third nerve palsy. Thank you.